All right, welcome to Roots of Reality Experiences. I'm joined by Dr. Keith Humphreys, who is a professor of psychiatry and behavioral science at Stanford University. His research focuses on individual and societal levels interventions for addictive and psychiatric disorders. Additionally, in the past, Dr. Humphreys was a senior policy advisor for the White House Office of National Drug Control Policy and is the author of many articles on topics related to drug policy. So, Dr. Humphreys, thanks for coming on today.
Very glad to be here. Thanks for having me.
So, when did you first get interested in drug policy?
Well, I started my career quite a long time ago now, 35 years ago now, working on a project that was studying people who were being treated for addiction, going
Yeah.
into public sector programs mainly. And we interviewed them when they entered and then followed them up afterwards. So I was mainly looking at it as a clinical kind of question: what treatments do you design? What affects the course of recovery? What predictors? What's predictors of overdose and all that? Um, but as I got into it, it became evident to me that treatment matters, individual decisions matter, but that all of us live out our lives in the context of laws and regulations that have, very large effects on us. And if you want to understand, say, addiction, you have to look at the policy frameworks that we put around it. You can't understand it just by looking at individuals, although even though that is important.
Yeah, that makes perfect sense. So, I mean, you have been in the field for a while now. Can you briefly summarize or what has been the situation in regard to drug use in the US since you started your career?
Yeah, so I started 35 years ago or so. The main drugs of concern was very much cocaine, and crack cocaine and violence associated with crack markets. And then in the 90s, there was at least in the Western United States, a huge concern about the rise of methamphetamine, both its use, but also its production, because the meth labs would explode and use a lot of toxic chemicals and burn people and so on. Those drugs have both withered a bit, actually, and then starting in the sort of mid to late 90s, we had this really unprecedented expansion of prescription opioids, which really changed the United States. And by an expansion level was about 400% per capita increase in a period from about 1998 to around 2010, 2011. And that put us beyond a level that any nation had ever had in terms of how much consumption there was, to the point that we were prescribing about one opioid prescription for every adult in the entire United States each year. And that generated, I think, as everybody knows, quite a bit of addiction, quite a bit of overdose. And then towards the end of that, then there was an introduction. As that is peaking, we have the introduction also then of the sort of return of heroin. Heroin had been the big scary drug of the 60s and 70s. There were still some heroin users after that, but markets had been pretty quiescent. But that became roaring back, including in places that had never really had a big heroin market. So the sort of Huntington, West Virginias and the Youngstown, Ohio's and places like that, traffickers realized that there wasn't a lot of law enforcement there. On the other hand, there were a lot of people who were addicted to opioid pills who might want to trade down to heroin, which is cheaper. And then not long after that, about depending where you are in the country, heroin starts coming back around 2013 or so. Fentanyl comes in behind that, in originally sort of within heroin, and now increasingly just sold as a standalone product. That starts out east, but now has come out west. We have quite a few fentanyl deaths in the last 3 years. We were insulated that for a while, and that's clearly the biggest concern. But I'd say all that I've said is about illegal drugs. Sort of point out throughout that entire period, the sort of elephant in the room is alcohol, which today still kills more people than all the opioids put together, and is responsible for more violence, more arrests, and more incarceration than all the illegal drugs put together. And that's one of the interesting things about drug policy, is that how many Americans think, including many policymakers, is they put alcohol in a separate category as if it were not a drug. But of course, pharmacologically, that's exactly what it is.
Yeah, that is interesting. Yeah, I mean, I guess it seems like, yeah, for a lot of policymakers, they're thinking about hard drugs just because, I guess, like the effects of them immediately are much more visible than alcohol is, and I guess because they're not as widespread as alcohol use is. It's interesting that we neglect that, though, the fact that it is such a, a big issue that we ignore.
Yes, and it's also a helpful thing if you want to be drug policy analyst to recognize the role of alcohol, because it's very commonly said, if drugs were legal, we could regulate them easily.
Hmm.
But of course, experience of alcohol, and for that matter, tobacco, cigarettes, is not very encouraging at that level.
Yeah.
And the second one is, the only reason people go to jail for drugs is because they're illegal. And again, the number one drug if you go to jails and prisons, and I've been in many in my career, most common problem people have is alcohol,
Hmm.
because there's the pharmacology of it is such that with use and intoxication, people very clearly do things they would not otherwise do, including violent things, and that threaten public safety and result in people going to being arrested and incarcerated.
Yeah. I mean, thinking from a scientific standpoint, is it so, what is it like for you to sort of analyze human behavior then? You're constantly studying people that are getting addicted to different substances. What does that tell you about kind of our species in the big picture then?
Yeah, what a great question. I mean, that is, to me, the most intellectually fascinating thing about this area is that Homo sapiens are vulnerable to prioritizing molecules that have no nutritive value at all. We do not need them. And yet some of us will prioritize using them to the point that we neglect raising our young, eating, staying warm, having shelter overheads, all the things you would think would be evolutionarily conserved as extremely important functions of our species. If we didn't do those things, we wouldn't be around. And yet, these molecules can be prioritized more than that, which we see in addiction. And there's an interesting historical aspect to this, which is, you know, addiction was not a big deal for most of the history of our species. If you go back about 150 years, though, you get the birth of chemistry and modern chemistry, and you have, all of a sudden we invented cocaine, amphetamines, methamphetamines, heroin, benzodiazepines, and then that's coupled with the rise of global commerce. So tobacco as the plant is not that dangerous. Because it's very hard to inhale. It's sort of harsh. But when you have a global tobacco company that figures out, oh, we could blend this with Turkish tobacco, cure it so it's sweeter, people can inhale it more deeply, all of a sudden you start to have widespread addiction to it and widespread small cell carcinoma of the lung. And that was but not to the tobacco plant. That's due to the development of modern commerce and modern chemistry kind of meeting each other. And so that's why, we're in the fix we are, is that we've got old brains. We've got something old and something new. What's old is our brain, which evolved over tens of thousands of years. What's new is a much more drug-saturated environment. And we're not well equipped to handle those things. We're not evolved to very well to handle these potent molecules, and therefore that's why we have so much death and destruction around them.
Yeah, I mean that is such a fascinating thing because I think a lot of people, especially people that have never used drugs or been involved with it. I mean, people have had alcohol, but like the feeling that people get from drugs is something that I think is very hard for people to even understand, like how strong addiction is. How would you try to communicate like what someone goes through that's really addicted to something that's a hard drug or anything?
Yeah. So, we know, thanks to our friends in neuroscience, we know a lot about how the brain works. And, there's a pathway in the brain that communicates reward, which is be a simple way to say it is the signal that felt good and you should try to do it again. Now, having that pathway there is very important. That teaches us things throughout our evolutionary history, like when you were hungry and you ate, I felt good. Make sure to do that again. You were cold and you got warm. I felt good. Do that again. Be sure to have sex. Be sure to cuddle your vulnerable newborns. All those things together, we're getting that signal. Yeah, that's good. That's good. Do that again. That keeps us alive. These new kinds of drugs, new historically kinds of drugs, are capable of generating a response in that reward pathway that is a multiple of any of those experiences. So, the experience of taking methamphetamine or taking heroin, we can chart a neurotransmitter called dopamine and see, maybe 5, 10, 50, 100 times stronger than how people feel during sex or how they feel eating a fantastic meal. And so we get the brain gets the signal. Oh, that was really important to do, more important than anything else you're doing. So you should really keep doing that again. But it's bad information, right? Because the truth is that if you keep doing that forever, unlike all those other activities, you will ruin your life, ruin the lives of people
Right.
around you.
Yeah. Wow. Pretty crazy. So, popular sort of as of late, there's been several different cities in the US, and I know there's been some places in Canada that have sort of tried to just decriminalize drugs altogether. What have been sort of the results of that sort of new idea so far?
That's a really good question, and it's one that really helps to clarify terms. So when people say decriminalization, they mean all kinds of things. Sometimes they mean like alcohol, like companies should be able to make it and produce it and sell it and market it. But in drug policy analysis properly, we call that legalization rather than decriminalization.
Okay.
For decriminalization, what we mean is you still can't make it, sell it, and it's still a crime, but we will not apply penalties to the user of the
Hmm.
drug. And
Okay.
sometimes that's say we won't apply any penalty. Sometimes it's we're going to reduce the penalty. So it might be something like, well, we've been putting people in jail. Now what we're going to do is write them a ticket. That's what happened, for example, with cannabis in lots of places around the world over time. The impact of it at the moment in on the Pacific coast of the United States doesn't look so great. Um, but it doesn't mean it's a bad concept in principle. I mean, we when California decriminalized cannabis possession, um, went from being a misdemeanor to being a ticket. There was a very, very little change in how much cannabis people used. But there was a drop of about 85% in the number of arrests. And getting arrested does real damage to somebody, especially to a kid, right? So
Yeah.
that they're successful decriminalization experiments around the world. Um, but so far, the Pacific Coast is really struggling, I would say, with its drug policy generally. I wouldn't say it's as simple as just decriminalization
Yeah.
caused it. I think you have the arrival in Western markets of North America of fentanyl, which had been more on the East Coast. That was going to cause challenges anyway. We have a lot of cheap meth, amphetamine, that was going to cause problems anyway. And then this was coupled with kind of a libertarian moment of pulling back on policing generally, letting a lot of crimes that would normally be punished, like shoplifting, vandalism, and go unopposed, and a general pulling back of any kind of enforcement around drugs, including things beyond the user, things like standing on a street corner with a gun in your belt selling fentanyl. And so that kind of libertarian moment, which we've been in for the last couple of years, has has made things worse. I mean, we already had a pandemic, of course, again to make things
Yeah.
worse. But if you look at death rates running up this sort of most libertarian part of the continent, which would be San Francisco and up through Portland, Seattle, Vancouver, it's pretty discouraging. And even beyond that, the quality of life issues are pretty severe.
Sure.
So in drug policy, we care about people who use drugs. We also care about everybody else. So being unable to have your child walk to school safely, or without seeing horrifying things, or elderly people being afraid to walk the streets at night, property crime, lots of robberies, lots of muggings, lots of shoplifting, destruction of businesses, which means then loss of jobs, loss of community amenity, loss of taxes. Those are the problems sort of struggling on this libertarian sort of strip of the continent. And that is why I think you're seeing reappraisals that the number of people who were for these things 24 months ago are now having second thoughts.
Yeah. Yeah, it's interesting. Recently I was in Toronto, Canada, and I know they had done some stuff with sort of loosening up the laws there for drug use, and it was pretty surprising. I've never been to Toronto, Canada before, but it seemed like every block I went to, there was someone that appeared to be under the use of drugs, kind of just stumbling around. It was really, really sad to see. Um, and so it does seem like, it's incredibly complex to figure out the balance in terms of, how do we get these issues without making people because obviously you can go and just arrest a bunch of people, but then you're just ruining their lives. And these people that are, desperate for help, obviously. So, how do you find that balance then?
Yeah. The I work a lot with people who make laws and policymakers, and I summarize a lot of it by saying, okay, we know what we don't. We don't want a carceral, racialized war on drugs like we had
Right.
in the 80s. So we've gone way far away from that. But we also don't like our current situation. So it's like it's stumbling for, well, what would be a policy response to what you saw in Ontario, that is not just reinstituting the war on drugs. Now, for some people, some activists would say, no, there is only the war of drugs and this. So if you do anything, it's a war on drugs, a racialized war on drugs. I don't believe that. Actually, I'm quite sure that's wrong. But a lot of policy discussions get pretty polarized that way.
Sure.
So, for example, you can use law enforcement the way it is used often with people who have serious mental illness, which is in the form of therapeutic jurisprudence. So the goal is not to punish somebody who, let's say, is laying in the street, passed out from a fentanyl overdose and at risk of being run over by a car. But you are taking them and saying, okay, we're going to use you're engaging in multiple forms of illegal conduct. We don't want to throw you in jail. We're not trying to hurt you, but we are going to mandate that you will get some help, whether you want to or not. And that is done with people who have schizophrenia, who are unable to take care of themselves and make decisions. That could be done with people with addiction who are very much in a similar kind of situation.
Yeah.
Um, and an interesting phenomenon in general about people is often people have a negative reaction to constraint at the time and are grateful for it later. So, teenagers are mad their parents make them do their homework, but then of course when they have a decent job 10 years later, they're like, oh, thank goodness my mom and dad made me do their homework. This
True.
is also true a lot in addiction. So
Yeah.
people get very outraged about, I'm so sick of my boss, my wife, my doctor, the cops all complaining about my heroin use and pushing me to change, and I don't want to change, and I hate all those people. And then when the person is in recovery a year or two later, they're you know just so profoundly grateful to all those people who cared about them enough to push them to make a change that they didn't feel they were ready to make.
Yeah, I mean that makes perfect sense because it's hard to imagine someone who's in that situation would be thinking clearly about their circumstances when you're under the state of needing drugs all the time. That's yeah, it's hard
Yeah,
to be rational. Yeah,
yeah, that's it. I mean, it's sort of like, if you went to a doctor and say my knees really hurt, and the doctor said, well, that's because you're missing some cartilage, and you're 50 pounds overweight, so what you need to do is become a jogger so that weight comes off. It's like, well, my knees hurt, I can't do that, and I'm obese. So like you're asking me, the health condition I have is preventing me from accepting the very advice you're offering. That's true in addiction. Is if you want to take a kind of Chicago economics school, well, people will just rationally sort out that this is a bad idea. No, because the instrument they need to make that judgment, their brain, is exactly what is impaired.
yeah,
Parts of the brain that normally, the forebrain stuff that exerts, self-control and sort of stops our bad impulses, is sort of less active than normal, and the more primitive parts of the brain that express that hunger, although in this case it's the hunger for drugs, is stronger. And so they're just not in a good shape to do that, to think about what's going to happen in a week, a month, a year, when what they're thinking about is what's going to happen in the next 90 minutes, because I need to get more drugs in the next 90 minutes.
yeah. No, that makes sense. Now thinking, I guess globally, the big picture. How does the U.S. drug addiction situation compare to that of other countries around the world?
Very common view people have is drug use, it must be caused by poverty. So it's got to be the poor countries that have all the big drug problems. Exactly backwards. It is rich countries that have all the big drug problems. And as countries get richer, like as they develop more serious drug problems, because it's a form of commerce. You have to sort of spend money to do it, and you have to have the money to do it.
Yeah,
So that'll be a challenge with economic development. I'm still for ending poverty. I mean, I don't want people to be poor,
sure.
but one thing I have to think about is, like, as people get richer, they will spend more money on tobacco, alcohol, and drugs, and there will be health consequences to that. We could though at least help uh, countries in that situation respond more intelligently, perhaps than we did, on many things. For example, how we handle prescription opioids, which we handle pretty badly. The other interesting tension internationally is agreements around prescription drugs are all global. They're under UN treaties, something like 195 countries signed off on. So if you're a Canadian or an American, your view of this is, well, we have way too many opioids. We need to have these treaties be very restricted because all these people are dying from over prescription opioids. But if you're a Malawian, um, or a Sri Lankan, your view is, are you kidding? We have people dying from bone cancer
Mm,
with no opioids available.
yeah.
We need more of these. So one of the things I've been working on internationally is like, how do you find that balance? So that, because opioids are terrific medications when used properly. So how do you get the treaties to do both of their important functions, which is to simultaneously protect people from addiction and overdose, but also give patients in pain access to these medications, and that's a challenging needle to thread.
Yeah, that's especially hard because all these countries have different needs and people in different situations, and sort of those one glove fits all type policies typically fail a lot of people. Uh,
Yes, that is correct. And countries also have different regulatory capacities too.
yeah,
So the extent to which you can build a secure supply chain, so that the medications are not stolen and they actually get to patients who need them, and that you have doctors who know how to prescribe them. That varies a lot around the world too. And so you have to sort of develop those capacities, regulatory capacity and in person power capacity in healthcare to make the arrival of opioids good for a country rather than bad for a country.
yeah, no, it makes perfect sense. So I'm curious, what are you currently working on these days?
I'm doing a number of different things. So I'm doing some stuff based on basic epidemiology of what are some techniques we can find out how much drugs people are actually using in the United States. This may surprise people. We don't really know how
Oh
many
wow,
people are addicted to heroin and fentanyl and all that. You think surely we know that, but what we have is we have household surveys. Call people up and ask them, and they tell us stuff, and those numbers are quoted widely. But those surveys don't count people in jail or
yeah,
prison. They don't count people who are living on the street outside of a homeless shelter. They don't count people in congregate kinds of living arrangements, like army bases. And they also depend on people telling us the truth. So they really understate it. So we've got a couple of projects to try to use different kinds of technology. One is wastewater sampling, like what was used during COVID. Well, just like you can measure how much COVID there is in a city, you can measure how much drug metabolites are there because people excrete them. We've got a wonderful project here at Stanford. We're trying to look at social media, and can you harvest the things people voluntarily put on the web to learn about new drugs and how much people use them. So I'm spending a lot of time on that. I'm spending time on this international issue of how do you get these treaties right. And then I'm working a lot with our California legislature. I'm based in California, on our current overdose crisis in the state. So everything from how do you get, like we just worked on a bill about getting naloxone into bars.
okay,
So because it's very common for people to overdose in bars. Also getting naloxone paid, this new over-the-counter naloxone, getting it paid for by insurers, improving the quality of treatment, and trying to find a productive role for law enforcement that asks them to do things they can do versus things they can't do. So, for example, keeping fentanyl from going from Mexico into California is not something California law enforcement can do.
yeah,
So it's far too compact, and they don't have the resources and all that. On the other hand, um, working on suppressing open air drug markets, that's something police officers can do. Working with the drug court system, using the power of the law together with health professionals to help people who are addicted who commit crimes, that's something else police can do. So those are the kinds of the big issues.
hmm. From all your research, is there something that sort of gives you hope about the sort of the crisis that we find ourselves in today when it comes to drug
I,
use?
I'll tell you a story of something not from research that really gives me hope, which is about 6 months ago, I was contacted by a high school student in Illinois who um, lost someone that she loved to fentanyl, and she managed to convince her state legislature to put naloxone in every high school in Illinois, and
Wow.
to provide yeah, it's people like that that give me the
Yeah.
hope. There are always interesting research findings, but the caliber of people, how hard they try, and contrary to what a lot of people think about politicians, I know many politicians. There's an enormous number of very decent, hardworking, caring people in politics. They may not be in the papers every day, but they
Sure.
are there. They are there, and it's gratifying to see that. And they experience this pain. Constituents come in and tell them, buried their child or their husband or their dad or their mom. Many of them also personally experienced it in their own families.
Yeah.
So that kind of thing gives me hope.
Yeah, definitely. It's certainly, I mean, especially with an issue like this, it becomes such a widespread issue that many people have some personal connection to the problem. And, as a result of that, everyone sort of becomes aware of it. And I think that maybe helps unify people to try to tackle it instead of just ignoring it. So hopefully we can make more progress on that front. Um,
From your lips to God's ear.
yeah. And what's the best way for people to follow your work?
Um, we ran a big commission with a medical journal called The Lancet in the university, and all the materials for that are online and for free. Just opioids.stanford.edu. That presents a really thorough analysis across all policy domains about the opioid epidemic. You can also see a model of different types of policies and what impact they could have on deaths in the United States and Canada. That's up there for free. Another place is the Stanford Network on Addiction Policy, which again is a website. All the materials we put out trying to help policymakers is there, and that's addiction policy. That's one word, addictionpolicy.stanford.edu.
Perfect. Well, thank you so much for coming on and sharing all your knowledge and all the work you do. So.
Thank you.